thank you all for joining the Rapid Fire Patient Safety Rounds 2.0 webinar. This is our second installment of this series. We're looking forward to it. A few updates before we get started. If you haven't, feel free to apply for membership at STS. We invite you to become a member and of STS if you're not already one. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. You'll enjoy a variety. So if you want to learn more, go to sts.org/membership. And I would like to introduce our speakers and panelists here. We are looking forward to a very interactive and dynamic presentation. So I will go ahead and hand it over to Dr. Moffatt-Bruce.
Great, thanks very much, Emily, and welcome to everybody, and thank you for joining us this evening. This is the second time that we've had a rapid fire patient safety rounds, and so we're really excited. Like anything in quality and patient safety, we try to improve upon it every time, and I think this will be no exception to that. This is a very unique format to do patient safety rounds in that it's truly resident run and faculty facilitated. So you'll see this evening that our residents, and thank you to our learners for contributing tonight, we'll be going through the scenarios, and then we'll very much tease out the pieces of the patient safety components as Joel will shortly describe to you hereafter. Please use the Q&A. That's what we will be monitoring. Dr. Walsh and Dr. Chedrawy are kind enough to be monitoring that. So please use that abundantly, and we'll be sure to be looking forward to that, to engage in this patient safety rapid fire rounds. So with that, I'm going to turn it over to Joel, and he will take us away. Joel, over to you.
Thank you very much, Dr. Moffatt-Bruce, and good evening, everyone. I'm very happy to be here. My name is Joel. I'm a fourth-year cardiac surgery resident at Dalhousie University, and that's in Halifax, Nova Scotia, Canada. And I'm very happy to present the QuIPS rounds today. I'm going to do a brief introduction, and then we're going to go through 2 mock cases as a group, which should be very exciting. We have no disclosures. As we all know, the delivery of cardiothoracic healthcare is complicated, and it exists within a complex healthcare system. Unfortunately, despite our best efforts, adverse patient events do occur. And when they happen, it's very important that we detect and critically evaluate them so that we can facilitate positive system improvements. Traditionally, M&M rounds have been used in this capacity. However, the procedures and protocols of these rounds vary substantially between institutions, and this heterogeneity translates into inconsistent improvements between institutions. To this end, we came up with the Quality Improvement in Patient Safety Framework, also known as QuIPS. And it really combines aspects from leading theory from quality improvement in medicine, from the Ottawa M&M model, from the Donna-Bedian model, which focuses on structure, process, and outcomes, and also phase of care analysis, which has been championed in a number of programs that lead cardiothoracic surgical quality. We'll now move through the QuIPS process. As stated, it's largely based on the Ottawa M&M model, and there's a few important components, thereby being appropriate case selection, structured analysis, multidisciplinary involvement, a facilitator, and an avenue for the bottom line or the outputs to be translated to the quality committee at your institution. In the QuIPS rounds, cardiothoracic residents lead the rounds. They prepare the QuIPS data sheets and present the cases during the QuIPS rounds. And cases can be mortalities, sometimes called failure to rescue, morbidities, or near misses. There's always a cardiothoracic consultant moderator that is paired with the presenting resident, and they should work as a team. The QuIPS round should include all key stakeholders, and this is really important because the quality of the QuIPS round is more fruitful when all stakeholders are at the table, and this is a very important takeaway. Here we'll see the QuIPS data sheet for cardiac surgery, and on the left-hand side, you'll see that there is demographic information, including the procedure and the STS or operative risk score, and then the 3 phases of care, which are the foundation of QuIPS, the preoperative phase, the intraoperative phase, and the postoperative phase. Below, you'll see there is an inflection point, again, with the preoperative, intraoperative, and postoperative phase. And really the inflection point is when there is a noticeable change in the patient's clinical trajectory. there can only be one inflection point. Event factors are seen on the right-hand side of the screen, and again, they're by the 3 phases of care. And event factors are areas of discussion and possible improvement. And you'll see that it's standardized. So for each cardiac case that is reviewed, there is a standardized set of event factors that are recorded. Here's our newly made thoracic surgery data sheet. And again, you'll see there's patient demographics, the 3 phases of care, inflection point, and event factors. On the right-hand side, you'll see there are some same event factors from the cardiac sheet. However, there are many that are unique to thoracic surgery. And an important takeaway is that these are just examples. If your institution has specific discussion points or event factors that they would like to use in their own QuIPS data sheet, we would definitely encourage that you include them. The QuIPS case presentation itself is concise, no more than 10 minutes, and it's really based on those 3 phases of care. The resident should suggest event factors in the inflection point, and these outcomes are ratified by the multidisciplinary discussion at the end of QuIPS rounds, and these outcomes are recorded in the data sheet. Why is this important? In 2012, the Michigan group published their analysis of the phase of care mortality, and you'll see the authors conclude that utilizing phase of care mortality analysis stimulates surgeons and hospitals to develop and refine mortality reviews and provides a structured statewide platform for discussion, education, quality improvement, and enhanced outcomes. Similarly, the Australian and New Zealand national audit had a similar conclusion. These findings can inform various stakeholders to improve the quality and safety of surgical care. National surgical audits provide a valuable and unique insight into issues affecting mortality in cardiothoracic patients. And the important theme here is that these are all retrospective reviews of morbidities or mortalities that use standardized event factors or clinical management issues to define recurring themes or recurring issues that can be targeted for quality improvement. So overall, QuIPS develops critical review skills and accountability by the resident, by the attending, and by the entire team. And really the rounds facilitate a sense of awareness because you will see recurring items, and the information that is gathered during the QuIPS rounds or the experiences of the team can perhaps better drive the team in the future to navigate these complex scenarios. Each QuIPS case is a data collection tool, and over time you will make a database that will identify specific areas for quality improvement at your own institution. And overall, we'd recommend to do this to enhance performance and outcome on the road to being a cardiothoracic center of excellence. We'll now move on to the mock scenarios, and I'm going to hand it over to my colleague, Dr. Rachel NeMoyer.
Hi, I'm Rachel NeMoyer. I'm a thoracic fellow at the Cleveland Clinic. So I'm just going to go through a scenario. It's a 59-year-old female who presented initially with some dysphagia. She does have an extensive past medical history with some morbid obesity, has NASH, rheumatoid arthritis, was on some medications for that, and interstitial lung disease. She underwent an EGD, which revealed mid-esophageal cancer and was biopsied and diagnosed as squamous cell. She underwent an EUS and it was staged as T3N1M0. She underwent a CAT scan and a PET scan, and there was no evidence of any metastatic disease on the imaging. She had been planned for neoadjuvant chemoradiation and again planned for surgery after that. So it was decided she would undergo a robotic Ivor-Lewis esophagectomy. This procedure, unfortunately, was complicated in the operating room. Once we got into the chest, there was extensive pleural inflammation and multiple adhesions to the lung parenchyma. During the dissection, there was noted to have a large air leak in her right chest at the end of the case, which obviously was something that was surprising. But at that point, we had left a chest tube in as we entered the right chest for the Ivor-Lewis esophagectomy. We did do an on-table chest x-ray, and it showed a left pneumothorax as well. And so a left-sided pigtail catheter was placed. At this point, the patient was transferred to the ICU in stable condition. However, post-operatively, she did remain intubated, and she had worsening bilateral subcutaneous air. She had repeat x-rays, which still showed bilateral pneumothoraces, and so 2 new chest tubes were placed bilaterally. She also, unfortunately, went into AFib with RBR, She was noted a few days later on post-op day 6 to also have bile coming from her endotracheal tube. And again, was noted to have bilateral pneumonias on her x-rays and was diagnosed with ARDS. At this point, after post-op day 7, she was finally transferred to a tertiary care center. And sadly, when she got there, she was so far gone that she required VV ECMO for about 10 days. She was noted, again, we said that there was bile coming from her endotracheal tube, and she was found to have a fistula between the airway and her conduit. At this point, she underwent an operation where the fistula was repaired with a muscle flap, and she underwent a defunctioning esophagostomy. She eventually required a tracheostomy as well. She suffered a stroke and was severely deconditioned. Unfortunately, she spent about 2 months in the hospital, but was eventually discharged to a rehab facility. And she did, on pathology, have a complete response to her preoperative chemo and radiation therapy.
Okay. Well, thank you, Rachel, for presenting that complex case. This is definitely a very challenging case, and it's one of those situations which epitomizes the saying that it's not the first mistake that causes trouble, but it's rather the spiral of the repeated mistakes that follow. So when analyzing this case down, let's start by breaking it down into the phases of care that we just heard about. So in the preoperative part of the case, we have this patient who's not really elderly, but as you pointed out, has several comorbidities, is likely on several immunosuppressive medications. She also has a locally advanced mid-esophageal squamous cell carcinoma, and there's an important factor missing in the decision-making process for her malignancy. What do you think that was in the preoperative phase?
Well, I think it's really important for any of these cancer patients to have multidisciplinary discussions about what the best care is, especially when you're kind of in that, like you said, advanced stage, to see what the newest options are, her age with her comorbidities, really to have a discussion if she could tolerate a surgery or if that's the best option for her. So I think that was really lacking here.
Yeah, I agree with you. I think all esophageal cancers, no two are the same. These are complex cancers, complex surgeries, and a complex patient cohort. They need to have a tumor board discussion. And perhaps if she had had that, there would be a full discussion of whether she truly is a surgical candidate. I'm not saying she wasn't, but you know, whether that was completely discussed is unknown. And also there was I would say a rather important adjuvant in her staging, or rather completing her workup, that was missing, considering this is a locally advanced mid-esophageal cancer. What do you think she would have benefited from?
Yeah, she underwent an endoscopy and an EUS, but she would have benefited from a bronchoscopy as well to assess her airway.
Yeah, I think, you know, it's unsure. We're unsure at this point whether there was airway invasion or not, but certainly for mid-esophageal squames, if this was in a multidisciplinary tumor board, doing a quick bronchoscopy may have shed light on a couple of factors before the operation. So before we move on to the intraoperative phase, if there's anything more to be added from the other panel members or the audience, otherwise we'll talk a bit more about the intraoperative component.
Monisha, I'm just wondering if I could ask a question of Rachel relative to the bronchoscopy. When in the process would that have been kind of an appropriate time to intervene, and what might have been the sequelae or the next steps after identifying, you know, an immediate issue on bronchoscopy?
Sure. In the intraoperative phase, I think when they're going under anesthesia for their endoscopy and their EUS, I think pre-treatment is beneficial just to see if there's any airway invasion at that point, because again, would change possibly what the treatment options are for her. And then obviously after she received chemo and radiation, again, it would benefit to get another bronchoscopy at that time when you restage her to see if there's any changes there as well. And then we'll discuss intra-op as well. I think it's really useful.
Great, thank you.
So, of course, we know all as surgeons that the time to prevent a postoperative complication is in the operating room. And there were several deficiencies or points in this case that could have changed the course of how this played out for this patient. So firstly, this was a robotic esophagectomy, which clearly requires a great amount of skill and experience in esophageal cancer and esophagectomies in general. And we know from the study of learning curves and outcomes that these are not easy cases by any means. I was concerned when looking at this case about the fact that despite adhesions, but despite what looks like a very tough case and a long case, the team continued to pursue a minimally invasive approach. So opening is not a failure, we're taught, and can be safer in multiple aspects, including visualization. So what did you think about this part, this approach and staying with the robotic?
Yeah, no, I agree. I think unfortunately, sometimes pride kicks in and sometimes patients are leading people one direction. Oh, I heard a robotic surgery is really great. It's less incision, smaller incisions and less pain. And so I think sometimes surgeons are pushed to try a little bit harder or to continue when maybe they should open earlier, like you said. And I think changing the mentality there is it's not a failure, it's what's safe and best for the patient. And as we say often, an alive patient is someone that can be happy and angry, and you really want to make sure you're doing what's right for them. So if it means opening so that you can be safe, get the surgery done faster, safer, less anesthesia time, all of those things, it's not a failure to open. It's something that you use in your armamentarium and your wheelhouse is having a better exposure, better feel of the tissue, and especially when there was concerns for being near the airway and dense adhesions, sometimes being able to actually feel that and see that in real time versus on the robot really can get you a better perspective of where things are.
Yeah, absolutely. And to your point earlier about bronchoscopy, I mean, if this was a tough dissection, getting things off the airway, this was the time to do a bronch and understand why that was happening. And, you know, whether all these adhesions contributed to a membranous airway injury, we'll never know. And it is also highly unusual to have such large air leaks after an esophagectomy, something that, you know, as you said, required a contralateral chest tube and an air leak in both chest tubes. So what do you think about that, and what else could have been done during that time?
Again, I definitely think a bronch is something that should have been done. And we routinely on all of our patients, even if there's no concern for an airway injury, we do a bronch post-procedure while they're still under anesthesia on the table, so that if there's any concern at all, we're aware in the operating room. But the air leaks and the bilateral pneumothoraces should have been a red flag as well, to absolutely get a bronch while still in the operating room so that we could investigate.
Yeah, so I agree. I think that we can all agree that this is an inflection point in the intraoperative phase.
Absolutely.
Before we moved on to the postoperative phase, I just wanted to see if there's any other comments from the moderators or the audience.
My main question through the case was about proceeding with the robotic approach, but you and Rachel definitely identified that as a key point in this case. So I have nothing further to add.
So looking at the postoperative course, so this really demonstrates the importance demonstrates the failure to rescue that Joel brought up earlier, failure to rescue from complications, luckily not a mortality. So there were several points of deficiencies where a potential deterioration could have been prevented. So Rachel, what do you think some of them were early on?
Yeah, and I think the big thing, as we're saying, is just to recognize that there was an airway injury. And I think that really continued to have her spiral. She was losing tidal volume. She was intubated for a long period of time, which again is not normal for patients after esophagectomy to have a prolonged intubation, especially since she was robotic and there was no large thoracotomy incisions that may cause some pain. So I think really missing the obviousness of the sub-Q air, the bilateral pneumothoraces that continued and persisted even with bilateral chest tubes, that was really a failure.
Yeah. And as we know, even if you have a small membranous airway injury, you combine that with a small leak, and now all of a sudden you have a big problem. You have a big fistula, which is exactly what happened here. There's a failure to prevent that from happening earlier on, and also to prevent that from progressing to a full-blown respiratory failure requiring ECMO. What systems issue do you see here?
I think again, sometimes we think we can handle everything. And I think not recognizing early on that she had a major problem and transferring her to a tertiary care center where they could have the ability to do ECMO or to possibly fix this early on, really, unfortunately, allowed this patient to suffer more than she probably had to.
Yeah, absolutely. We don't know whether this center was a high volume center to begin with in terms of doing esophagectomies, but even that early on, she was clearly struggling, and maybe that's the point to go to a center of excellence where everything is available to get this patient through what she needed. Any other comments about the postoperative phase?
I think we're good to go on, Monisha. I think that you and Rachel have covered it very, very nicely.
Thank you.
Thank you.
All right, I think with that, I think, Joel, we're going to go on to scenario 2. And you normally take about 10 to 15 minutes per scenario, right, when you run these in your own center?
That's correct, yeah.
Perfect. All right, we'll move on to scenario 2 then, please.
Hi, I am Takuya Ogami and one of the cardiovascular fellow at the University of Pittsburgh Medical Center. I'll present the next case. The patient was 88-year-old male with a known history of aortic stenosis with ejection fraction of 35%. Aortic valve area was 0.95 square centimeter, and mean gradient was 25 millimeters of mercury. The patient was being evaluated for TAVR. He has a history of coronary artery disease, severe cardiostenosis, abdominal aneurysm, COPD, and CKD. He also had severe degenerative spinal disease. He presented to the emergency department with acute heart failure. Repeated echo showed ejection fraction of 20%. He was admitted to a hospital and underwent cardiac cath. The procedure was complicated with air embolism and cardiac arrest. He regained a pulse after 3 minutes of CPR. Following those events, heart team decided to proceed with TAVR during the same admission. After 5 days of medical management, he showed some improvement of heart failure. His STS score was 4.5%. He underwent TAVR through left transaxillary approach. Self-expanding valve was successfully implanted under TEE guidance. Excellent result achieved. During the first 24 hours, he required support with dobutamine, volume replacement, and NIPPV, but he was weaned off dobutamine in the next 24 hours. However, he developed progressive dysphagia and increasing shortness of breath on post-op day 2. Transthoracic echo showed good function of the valve, no paravalvular leak, and the ejection fraction was somewhat recovered to 30%. On postoperative day number 4, he developed severe epigastric pain and acute renal failure. CT chest revealed moderate right pleural effusion and pneumomediastinum. On postoperative day 5, IR placed pigtail into right pleural effusion, which revealed cloudy drain output. Broad-spectrum antibiotics was started. GI was consulted for suspected esophageal injury, and esophagram was ordered. which showed an area of extravasation. On postoperative day 6, he underwent EGD, which showed a large defect in the mid-esophagus, and the covered stent was placed. When patient was admitted to ICU, he was markedly hypotensive and resuscitated with lev-fed and volume replacement. However, over the next several days, he continued to gradually deteriorate with ongoing sign of sepsis and developed multi-organ failure. On postoperative day 12, the family made a decision to withdraw care and he expired.
Okay, Tak, thank you for that. Obviously this is a very complex case, as many of them are. And our job here is to try to dissect this down to, what are the key factors that are involved here. And one of the first questions I think we always have to ask ourselves when we have a problem like this is, were there other alternatives that we should have considered? Was this the right choice for the patient? And were the right processes being made in this procedure? What do you think?
So his STS score was 4.5%, which is intermediate risk. But he's 88 years old, and apparently there are lots of complications, comorbidities. So SAVA was probably not appropriate for this patient.
Okay, so TAVR is an appropriate choice for him. There are a lot of complicating factors in here. What are some of the things that really stick out to you that you have to be aware of?
For TAVR, the history of abdominal aneurysm is one of the considerations for the access site approach. But for this case, complication is obviously esophageal injury. Then I mentioned the severe degenerative spinal disease. Sometimes when you insert the TEE, that might compress the esophagus on the vertebral body. So I think I would like to highlight this comorbidity as a risk of the this complication.
So when we're, if we're looking at this, where do you think the inflection, where is the inflection point in this case? I mean, that, I purposefully threw a lot of complications in here as sort of distractors. And one of the things in the QuIPS process that I think is critically important is that we learn to dissect down to what is critically important in the discussion here, and not to get lost in the weeds, if you will. So, we've got all these comorbidities and a procedural complication, but what is the real complicating factor here?
I think it's postoperative factors.
And what is it that you think is wrong in the postoperative phase?
So
where were the opportunities to improve in the postoperative phase is a good way to put it.
I think we could have identified the complication sooner and acting sooner. This patient started to have that epigastric pain on postoperative day 4, but CT chest showed the pneumomediastinum. But IR intervention was done on the following day. Then a GI consult was on the following day. I think those are the delays.
And I would agree with you. I think, there's a 48-hour delay in here. In I think it was recognized. And an important thing here, a couple other important things to think about here is that there's not necessarily an episode of negligence in the operating, although it's a procedural complication. This is an extremely rare procedural complication. To have an esophageal perforation from a transesophageal echo, if you look in the literature, the estimated incidence of that is like 1 in 10,000. So it's, there are a lot of TEEs done, and very, very few of them ever result in esophageal rupture. seems to be a little bit delayed. Can you think of any other reason why a transesophageal echo might cause an injury to the esophagus that we need to be aware of that could be a delayed diagnosis? You know, most of the esophageal probes will turn off if they get too hot, right? But, you know, sometimes that doesn't always happen. And maybe he has a very friable esophagus to begin with. He's 88 years old. So the other possibility is this could have been due to, you know, the probe just overheating and causing a burn, and then you get a delayed rupture 2 or 3 days later from the burn aspect of it. Again, very rare complications. So the point here is that this is not necessarily, even though it's an intraoperative complication, I don't think it's necessarily a matter of negligence. So that's not really, as you pointed out correctly, I think what we're trying to point out here is that's not where the inflection point is. As you pointed out, the inflection point is in the postoperative care and not recognizing it more quickly. So then what should have, if you were to have this, if you would have been there and been the responsible, you know, surgeon for this, what would you have done differently? We have done differently.
I would say I have acted more quickly. To do that, probably communication is important. Communication between radiologist, GI, and thoracic surgeon, and IR. So everything could have been done in one day, or in a couple of hours should have been done.
Yeah, you know, generally speaking, when we see pneumomediastinum, you know, that means I have to rule out an esophageal injury as an emergency. You know, you could have a pneumomediastinum due to bronchial injury, or, you know, we've all seen people who have severe COPD and get coughing spells and, you know, develop little, you know, this pneumomediastinum as a benign incidence, but, you know, not in a patient who's now describing severe epigastric pain, having dysphagia. You know, all the signs and symptoms were there. What were some of the things, though, that may have led the team not to be as concerned as they should have been? What are some patient factors that we need to take into consideration that maybe fooled them as they looked at this case?
So patient is 88 years old and has multiple comorbidities. Maybe patient did not react as severe as other younger people react. Like inflammation wise, maybe he didn't that much because this patient had the esophageal injury, and patient didn't declare until post-op day 4. So I think that's a thing might cause the delay.
Yeah, and I agree with you completely. I mean, these elderly patients don't always mount those rapid immune responses, the surge response. If this patient was 65 years old, he probably would have had a white count of 30,000 and a fever of 103 on post-op day 4. But he didn't. He had almost a normal white count. He had no fever. He was just, his main symptoms were more his complaints of dysphagia and the epigastric pain. From a laboratory biological standpoint, he didn't really demonstrate anything. So, I think people got fooled. But, I think you're exactly right that, a pneumomediastinum is you have to rule out a surgical emergency as your first thought. And in that respect, then, were the treatment that they applied even adequate in your mind? Now, we put a pigtail catheter in the pleural space. Is that an adequate treatment?
For gold standard, it's, I believe, drainage and washout. So, meaning operative intervention.
And it doesn't need to be, the guy, again, the gentleman is 88 years old, so I think they're trying to be as conservative as possible, but, certainly try to stick a scope in there. You could, open up the mediastinum, put a good chest tube in, get good drainage, wash it out. And, do you think it's appropriate to wait 48 hours to put an esophageal stent in? I mean, I think that's appropriate treatment, I don't think he needed any. The other option would have been what? To do a diverting esophagostomy, as we saw in the previous case, defunctioning esophagostomy, and you know, a feeding tube in the stomach and some things like that. Again, getting very, very aggressive. In an 88-year-old man, that's, you know, it's probably a death toll for him. But you know, I think there's a middle ground here where we were not aggressive enough. So the inflection point is it was in the post-operative phase there. Any
Steve?
other members of the group have any other comments on or suggestions or thoughts on this?
Steve, it's Susan. Chris from U of T has a question about the inflection point, you know, being even earlier in the preoperative phase, in that, you know, the use of the TEE, you know, and the appropriateness of that.
I understand that. I think that's a good point. You know, if you see a patient, first of all, I think, you know, many times, you know, in these procedures, the TE may be put down by the by the anesthesiologist who may not have even looked at the preoperative CT scans or anything to see if there's any restrictive things going on there. But on the other hand, when it comes to doing TAVR, it's become the gold, you know, TAVR, transesophageal echo is the mechanism that we traditionally use for positioning of the, making sure we're coaxial and making sure we don't have paravalvular leaks and everything else we need to do to position that TAVR valve. So other than using fluoroscopy, if we were to have thought about it and had seen real hallmarks of a problem, potential problem, I still think TE would have been the way to go. Again, I'm not sure that it was a negligence on the part with the TE. I think it was an unrecognized injury that you know, just could have happened, but just not recognized early enough and treated early enough in my mind.
I could just add a few more comments. You know, when we were going through the case, once I saw the word dysphagia, you know, a flag went up. You know, you would not expect that after an uncomplicated TAVI, even with, you know, the comorbidities that he had and the preoperative events that he had. Once I saw that, you know, a flag went up, and I really realized that, you know, this is the inflection point, I think. And sure enough, in the next slide, we saw him the days after, he's recognized to have the esophageal complication and sepsis. So just as a resident learner, something I've picked up through seeing a lot of QuIPS cases over the years is that it becomes a bit easier to tell when normal care is deviating and when your senses need to be a bit more heightened and attentive. So complications like this are recognized adequately and treated in a reasonable time period.
And then Joel, one of, you know, and all of you, one other thing that I noticed, and it's not in the sort of the data collection aspects of the coding parts of your sheet there, except in the preoperative phase where we have interprofessional decision-making error. What we're really talking about there is a team approach, as Rachel talked about very well. You know, that team approach to decision-making preoperatively. I think that team approach to decision-making continues through every episode of care. And perhaps that needs to be included in the intraoperative, maybe not so much intraoperative, because you really, the team is much smaller between the anesthesiologist maybe and the surgeon. But in this particular case, you would have a cardiologist that's a surgeon and an anesthesiologist. But in the postoperative care, we've got, you know, one of the other things I tried to build into this scenario a little bit was that we've got one of these situations where everybody's taking care of the patient, but nobody's taking care of the patient. Now you've got an intensivist, you've got the surgeon, you've got the GI guys, you've got the cardiologist, and everybody's rounding on the patient, but nobody steps in and makes a decision on what to do. So the, you know, teams only function well when teams are led well. And so I think there was a failure here. I tried to build a failure here into the team decision-making process too. And maybe that needs to be somewhere encoded into our pre-op, intraoperative, postoperative phases as an additional coding. And I mean, I think that's one of the take-homes that we can offer the audience here, is that although we present a template, that template is certainly modifiable to your needs and additional thoughts that you have. And so there's one suggestion for modifying that.
Steve,
And
it's
this
Susan
gentleman
again.
this gentleman, you know, he's very high risk. Even in the best of hands, if we recognize things going on right away, he still might have passed away. You know, this is often a lethal complication, unfortunately. But still, we can learn from it and do better.
Absolutely. And so thank you for presenting that. And I think it just speaks to how complicated these cases can be and how sometimes even if you have lots of people watching the patient, we have to always be so aware of what things that just don't feel right. Like Joel said, the dysphagia, etc. So thank you for that. Any other questions or comments? Just looking at the, oh, there, Eddie.
Thank you, Susan. I think what Steve is describing is an interprofessional decision-making error, but not in the preoperative phase, in the actual postoperative phase.
Yeah.
And there's an opportunity there to intervene at the system level and ask a few simple questions. Is your ICU a closed ICU? Do the other attendings have a say in the decision-making on the day-to-day basis? And you really want to standardize that at the system level so there is no confusion. And that way you'll be able to provide more efficient care, probably more effective care, because you're right, this postoperative issue could have been dealt with probably a little differently had there been more communication and more collaboration with the multidisciplinary team. So I think you are identifying a critical postoperative issue. We have it on the QuIPS sheet in the preoperative phase as an interprofessional decision-making error, but you're right, maybe it should be also in the postoperative phase, and there is a system level intervention we could do there.
Excellent point, Eddie, and I think it speaks to not only this case but also the last case as well, because these patients are cared for by multiple experts, and I think that's probably throughout all the phases that there needs to be that conversation and that understanding and communication. So thank you for that. I think, Joel, what do you think? Can we move on to the last part of the presentation, kind of the summary and all the great output of these type of rapid fire rounds?
That sounds great. So thanks everyone for presenting those two cases. At the end of today's session, we wanted to give the attendees and the audience a sense of what the QuIPS database can look like for an institution, because I've mentioned it quite a few times in the introduction, and I want you to get a feel of what it looks like and how you can use it. So this is what we're going to go through is fictitious. It's not real data. It's going to be the mortality analysis through the QuIPS framework of 104 patients. And again, you know, we just saw two cases where there was a very granular analysis of the phases of care, but overall it's with an N of 1, it's sometimes hard to, you know, think if you can have an effective or efficient intervention. You know, there's power in numbers. And if you analyze a number of QuIPS cases, you can really have directed quality improvement opportunities. So really all the database is transcribing the patient demographics, the event factors, and the inflection point from each QuIPS case into a database. And by no means does this database replace other clinical or quality data collection programs, because again, this database is representing the QuIPS format. So it's complementary, it's not in replacement of, and really it's going to identify those specific quality improvement opportunities. So on the left-hand side, we see the QuIPS mortality analysis by operation type. So in this data set, 18% of the mortalities were concurrent CABG valves, and moderate and high risk CABGs were the second highest operation at 16%. You'll see on the right side of the screen the distribution of the STS or operative risks of the mortality analyzed, and you'll note that 42% of the mortalities had an extreme high risk over 20% mortality. When we look at the inflection points, you'll see that the majority are in the preoperative and intraoperative phases. So 80% are in those two phases, and that's considerable. You'll see only 20% of the inflection points were in the postoperative period. You'll note that the event factors in the red don't necessarily correlate with the inflection points, but that's okay. As we saw in the two cases, there can be many event factors. There are just areas for possible improvement. So it's definitely okay to identify more than one. And in fact, that's something we would encourage. When we take a closer look at the preoperative event factors from this fictitious data set, we see that high operative risk, severe comorbidity, preoperative cardiogenic shock are the most common event factors. So these are recurring themes in the QuIPS database. In the intraoperative phase, we see unexpected technical challenge, surgical approach choice, and unanticipated injury or complication are the most common. And these seem fairly broad, but what you can do is you can go back and do further analysis on these specific cases to see what the exact issues were, and if there are modifiable structure or process items that you can intervene on. In the postoperative phase, we see that heart failure, adverse event management, sepsis, and pneumonia were the most common. So just looking at this very quickly, this might initiate a quality improvement initiative looking at the pneumonia prevention packages in the ICU, given the high prevalence of pneumonia and sepsis in the postoperative phase. So again, just a very, very brief overview of what the QuIPS database can do, but we just wanted to make sure the attendees could maybe visualize what some of the benefits are. So in summary, QuIPS cases are presented by residents and they're supported by faculty. The quality of the QuIPS rounds and the database rely on the engagement of all team members. And the data collection process enables targeted quality improvement opportunities that are specific for your institution. And again, the QuIPS data sheets can be modified to fit your needs. And overall, the QuIPS seeks to enable a psychologically safe culture of transparency where patient health and safety is the focus and patient-focused improvements is the goal. I'd like to thank the STS for having us here tonight and for all the attendees, and I'll hand it over to our chair, Dr. Moffatt-Bruce, to close.
That's great. I'm wondering if, Carol, we could have a little bit of a gallery view. So, because I think that there's probably some questions that will come, and maybe we can even quiz Joel and Rachel and Taka as to how it feels to be presenting these cases as residents and as learners in this new format, which is very different than the way that we would have been, engaging in the traditional M&M rounds. Maybe I'll Rachel, I'm wondering if I can put you on the spot and just can you give us a bit of a sense of what it was like to have to present this type of case?
Sure. I think in the virtual setting, you're saying, just compared to being, yeah. So I think I was a gen surg resident the last couple of years too, before I did CT. And so I think it was definitely a transition to start presenting, and the fear of having people stand there and stare at you was definitely added a little bit of fear and anxiety when you were presenting. So it's a little bit different just from that perspective when you do it virtually. And I think at first people weren't sure how to answer questions and butt in. And so as things become more streamlined with the chat version, I think it's easier to present as well and keep it cohesive and productive. But it's definitely been a transition. And I think just with the oral boards going virtual and things like that, it's nice to get used to presenting this way so that you're more comfortable when you're doing actual tests and things like that.
Excellent. Thank you for that, Rachel. And I think that what we're seeing is that participation from lots of different team members is probably more possible now because, and I think, Joel, you probably have, do you have something to add to that? And just from the level of participation relative to these rapid fire rounds in a virtual format?
Yeah, I think one of the strengths of QuIPS is that it has the structured format. And you saw on the QuIPS sheets, it's not just surgical event factors. There's anesthesia factors, there's perfusion factors, there's the oncology team. So it really is a framework that facilitates the group discussion. So I think that's a strength. And we've been doing QuIPS at our institution literally since I was at PGY1. So I've had a lot of good experience with it. And I will say, as a junior learner, having that structured format to approach very complex cases is very useful. You can work through it in the 3 phases. You can use the event factor sheet to maybe pick off some things that you weren't aware of or haven't learned about. And the second strength is that it allows you to, again, find that common ground with the attendings that you're working with. There are some cases where, as we saw, surgical approaches or decision-making could have been optimized. So I find that it's a great way to make a rapport with your attendings and have a positive relationship that way. So personally, I've seen many benefits with the QuIPS, and it's something that I look forward to each month when we have our rounds.
Steve, over to you.
You know, I was a resident back in the days. Garrett may remember him, and a couple others, of Alex Walt, who was the STS, or was the chairman of the department of the American College of Surgery back in the 80s. And Alex used to sit up in the front, and he would put his arm over his chair, and he would look back for the youngest, most vulnerable resident he could find. And it wasn't always the kindest event that we went through. This is so much more, I think, engaging. It's a pleasant event. It's encouraging. It's learning. I'm excited to see what the Rachels and the Joels and the Tacks of the world are going to do for us with this, as we've learned to become maybe a kinder, gentler individuals ourselves. But I think we're learning too with this. We're learning, how to be that, how to encourage, how to get this type of feedback back. It's a whole new way of doing things that takes away that fear and punishment that was involved with an M&M conference that nobody learned from. Just nobody learned from.
Those are very fair and wise words as well, Steve, that what we've done in the past isn't always the best way forward. So, congratulations to the team at Dal and others that have now kind of adopted this format. I think too, the structure to it, it's so complicated, these patients now that we have to face and work with, that really breaking it down to and making us think through the different phases of care, that really, really helps us understand where the systems issues or where the interventions can be put in place so that these events aren't repeated going forward.
I had a couple of questions for Joel, and also for Eddie, too, since this is your baby. You're looking at event factors, and they don't necessarily correlate with the inflection points. But do they point us in the right directions with that, where we should be looking, and how do they do that? And aren't the event factors really pointing us towards systemic issues within the phases of care? Isn't that what they really do for us?
Steve, it's all about culture change. And, in the older days, culture change came from the top down. Now it comes from the bottom up. And I think when I usually moderate QuIPS, I start with an open-ended question. I'll ask the resident, well, what happened here? And I want to hear their opinion on it. From there, they kind of identify the inflection points, they identify the event factors, and they almost always point in the same direction. And it's amazing when you see it from the learner's perspective in a truly culturally safe environment. They're curious, and it's their curiosity that drives our decision-making in the end. And our system level changes end up coming from their curiosity and the questions they ask. So I think having the learners involved, and more importantly, having stakeholders from other specialties. So, I love hearing anesthesia's input, right? Everything that goes wrong in the OR, we say is anesthesia's fault and perfusion's fault. But when anesthesia is all of a sudden in the room sitting next to you, you get to hear their perspective, and sometimes even their learner's perspective. Sometimes the anesthesia resident will question us. And I can tell you, it raises a lot of questions in my mind. So I think the learner's curiosity drives this process, and it helps us identify at the system level, maybe we should do things differently. Things aren't the way they were when I trained at McGill 20 years ago. And, times have changed. And I think QuIPS is a way to create an environment where they can identify the inflection points, they can identify some event factors, but they almost always point in the same direction. And they help us identify where we should be going and how things are done differently now in the hospital. Like Susan mentioned, the preoperative phase is so complex now. It's not just the cardiologist calling us or the pulmonologist or oncologist calling us with a consult. Now there's 10 other people involved that want to be part of it. And the postoperative phase, as you brought up earlier, there's so many stakeholders that come by, as you said, who has ownership of the patient in the end. So those system level issues that we can actually fix, but we only fix them by hearing that learner's curiosity. Well, who really does follow the pneumothorax post-op, and who really does follow the low cardiac output syndrome post-op? So I think it's a nice exchange of information from the learner to the mentors or the moderators. But I think at the end, they should all point towards culture change and system level changes. And I think that's what we initially started off wanting to get out of QuIPS back when we started it 4 or 5 years ago.
So I'm going to ask you one other quick question then. So you've applied this to the learning system within, academic center. How do we apply this then? And this is a rhetorical question. How do we apply this to the community hospital? I mean, 60 or 70% of heart surgery cases done in the United States, and probably, not quite as much in Canada because you're more academic, I believe, but in the United States are done in community hospitals. 150, 200 cases a year where there's no residents. So how is this applicable to that? And how?
At the end of the day, it really goes back to that curiosity. And we as professionals, as attending surgeons, academic or private practice, we should always be asking ourselves, how can we get better? How can we improve on what we do today? Like Susan mentioned, maybe what we did in the past may not apply today. Maybe what I'm doing today is not going to be applicable a year or two from now. So I think the process is still there. Whoever presents the case ideally should have an objective moderator moderating the event in front of a group of multidisciplinary stakeholders. That's really the essence. I think I love the residents involved because we're in an academic medical center. We want them engaged in the process. But at the end of the day, it's QuIPS, it's quality improvement, patient safety. Who's generating the conversation? Could be a learner or could be the surgeon who did the case. The moderator ideally should be a third party, so to speak, who's really there to moderate among the stakeholders. And for me personally, when I moderate QuIPS, I really just stick with open-ended questions. I just ask the learner, what do you think happened here? I don't like to say, what do you think went wrong? I like to say, what do you think happened here? Just so I can get them to start talking. And I think that's really where the beauty of it is. You want to make it safe for them to express themselves. And, as I mentioned before, I think it's their curiosity that drove the process. And it's evolved quite a bit, as Joel mentioned, it's evolved quite a bit over the last few years, but their curiosity drove this process. I was happy to set up the framework, but it's really their curiosity that has led to system level improvements now.
Yeah, I always like to use opportunities for improvement.
Go ahead.
Yeah, I just want to say one thing is that's a little bit along the line of what Steve was saying is before we throw out the Socratic method and the good old days of Lloyd and LaClain kind of making us all sweat up at the podium when we had to present M&Ms. I think it's important that we realize that the systems are complicated and the surgeon is part of the system and we have to be aware of all the components of the system. I like how we've broken it up into preoperative, intraoperative, postoperative, as we always have, but this tabulates it very well. But at the end of the day, it's the surgeon that's got to fill out the death certificate. So we have to take personal ownership of the system, understanding the weaknesses of the system that we work in, and realizing that we have to be aware and good situational awareness of the patients coming to us or referred to us. And we have to do our due diligence and go over and make sure that the bronch was done, to make sure that we're operating on the right patient. And is it the right thing to be taking an 88-year-old who's just had a cardiac arrest to a complicated procedure? Maybe that patient was trying to tell us at the initial arrest that maybe we shouldn't be doing more. So at the end of the day, it's the surgeon's responsibility. It is a kinder, gentler time, but we still have to have the same sense of ownership in our residents and our personal faculty that we are responsible for the patient, and we can't dilute it by the anesthesiologists and perfusionists. We have to be totally responsible for the total care of that patient.
Well, thank you for that. Thank you for that, Steve. Thank you for that, Garrett, and all the participants today. I think Garrett has wrapped it up very nicely for us. And a huge thanks to the learners for presenting, to our moderators for teasing out the inflection points, and thank you to everybody at STS for allowing us to be here. Emily, I'm going to turn it over to you and thank our audience as well. I think you just have a couple of slides to remind us of some.
Yes,
go ahead,
thank
Emily.
you.
Yep.
Yes, thank you so much to our speakers and moderators. That was a fantastic session. We just want to remind everyone that we do have the 19th annual perioperative and critical care conference coming up. It'll be in September. The agenda will include a dynamic present. It'll have awesome panels, and we'll have topics such as ICU dilemmas, ECMO challenges, and contemporary management of atrial fibrillation and more. And then also we have our next STS webinar coming up. It'll be Arrest After Cardiac Surgery. Is your team ready? And that'll be the next one next Thursday. So thank you all for participating.